Well, welcome back to the podcast. We're here talking about the depths of healthcare. I'm your host, Ben Iiames. I'm really excited for the episode today. Got a guest, Dan Cohen, who's joining us. Dan, want to introduce yourself and tell us a little bit about yourself?
I appreciate it, Ben. As you've introduced me, I'm Dan Cohen. I'm the president and co-founder of Adhere Plus. Adhere Plus is a telehealth solution data analytics company where we work with providers who are treating patients primarily in a pain management verticals, but our platform is chronic care based. So we also do work in behavioral health, bariatrics, and similarly sided material. I've been with the company for about 6 years now as employee one. And we've been building it out slowly. Prior to that, I've spent the better part of the last 25 years in healthcare on both medical device development and pharmaceutical development. In pharma, I've played a role in 11 of the 14 FDA approvals of products that are abuse deterrent, tamper resistant technology for opioids, whether that's been in the data in the label or a declaration that they're ADF. Devices. I've brought devices to the market for bariatrics and vagal nerve blocking, turned silicone gel filled breast implants to the market and other related issues. And most of my work is on the regulatory side in Washington, D.C., Congress, FDA, CMS, and the related fields.
Gotcha.
And that's been my second career.
Wow. How did you find your way? I mean, what intrigued you enough about Adhere Plus to be employee one?
I had uh, just completed the development of Apidas, which is a prodrug of benzhydrocodone acetaminophen, a Vicodin analog, if you will. And we brought that to the market. It was a battle with the agency, not about approval of the drug, but getting the abuse deterrent language in there, in essence, because it's an estrase-based prodrug and with no esterases in the nasal mucosa or in the bloodstream, you can't snort it or inject it and get a high. You can only wait till it falls down into your stomach, goes through the intestines, and the esterases release the opioid. Getting that approved was a big effort, and I thought that was a good time to retire. So I worked on my handicap drop, my pickleball game got in great shape. And in 6 months, I was bored to tears and mutual friend together with the original founder of the company, which was on a patient compliance mission.
Okay. And this is like now it's turned into a second career. It's the post-retirement career. I mean, what keeps getting you up to kind of keep things moving along?
Well, we have a fascinating challenge and we're able to impact patient health with it. I mean, care plan adherence and medication compliance for chronic patients is one of the biggest issues in healthcare. You can pick any number, but it ranges from a low of 450 to as much as $700 billion a year in losses to the healthcare system because patients just don't comply. And the simple fact is, the farther you get away from an acute event for a chronic patient, the harder it is to get them to continue their therapy, to continue taking their medications. Uh, that is what drives costs because patients get sicker sooner, they have poorer outcomes, and all of us, including the patients, end up paying for it. So if we can find a way to make patients more compliant with their care, then simply they'll have better outcomes than patients who
Right.
won't comply.
Right. How are you? I mean, so let's get into a little bit of the nuts and bolts now.
Sure.
What are your tracking systems like? How are you finding out if your patients are adhering? Are they like on a checkbox kind of schedule, or is it like automatically tracked in some way? I
Well,
guess.
and you work in ERs and you're a PA, you work with physicians. One thing neither you nor the physicians you work with have in your day is any additional time to do anything else. You have very little time to sleep, and we're doing your podcast during your sleep hours, I'm sure. So all of that becomes a challenge. So the first thing you have to do is work within reality. Second thing, when fee-for-service went away, physicians were placed in the uncomfortable position of running a business, which they had no training for and no background. In fact, I will say to any doctor that physicians are the worst businessmen in America. It's not
It's
their
true.
fault. They're not trained for it. And then you have something that is entirely different from the rest of the business world. You have an ethic to provide service to your customer, even if the customer has no intention of paying you for the service. Now, if I'm selling cars, I can repossess the car. I can't repossess a medicine or a care plan, nor as a physician would I want to. Someone has to pay for it. And so that becomes a challenge. So what we've done, what public policy has done, is created opportunities to deal with the healthcare crisis of having physicians available to treat. You're from Colorado, you're in a rural area, you know that it's challenging to find a physician. I know in even more rural areas, such as Montana, you can drive 6 to 8 hours and not find a physician. You'll eventually get to a nurse practitioner that has the ability to write scripts. When we deal specifically in the area of pain management, and that we've created some policies in Washington that come out of the opioid crisis.
Hmm.
2018 CARES Act, for example,
Yep.
put a mandate together, and I was one of the ones responsible for writing the CARES Act,
Mm. Wow.
which required patients to be in front of their physician face to face every 30 days to get a script renewed if they were on a Schedule II substance. Now, the problem with healthcare policy is it's made in the Boston to Washington corridor. And if you live in the Boston to Washington corridor or in Southern California, I can drop you down any point in those cities, blindfold you, spin you around, and in 20 minutes, you'll find another hospital system. Rest of America doesn't work that way. And telehealth was started in 2010, 2011 to address the healthcare shortage. Unfortunately, it was designed by bureaucrats who just thought, well, we'll just teleport the physician's office from downtown DC into Missoula, Montana, and solve the problem. Not their fault, again. They didn't know what they were doing, but they started a process which was very important. We started to get services where we started our company, which digital evaluation and management treatment, but it was too labor intensive, too expensive for practices. And what's changed healthcare, particularly for musculoskeletal conditions, is the advent of remote therapeutic monitoring.
Hmm.
This became a system where physicians and patients could communicate with one another, create a proactive care model, and the physician would get fairly paid for their services. That's where we come in. We've developed a process where patients and physicians can communicate. The physicians get compensated for it, the patients get better care, and society gets a lower cost of healthcare and healthcare
Hmm.
delivery. And we can go into the way we do that at Adhere, which is, I think both fairly unique and very simple. We'll start with the simple part. When
Yeah.
you went into PA school, when a physician goes into medical school, and we know the difference between medical school and PA school, physicians get 4 years to get all of their training in medicine. You get 1 year to get the exact same training in 4 years to get to the same.
Glad you know that.
So I do know that, and PAs are the heroes of the healthcare system right now. But one of the first things you learn is the more often you touch a patient, the better the outcome's going to be. Well, in our platform, our physicians touch their patients every day. Now, it's a quick 20-second touch, but in that 20 seconds, you have the psychological impact of the physician sitting on the patient's shoulder and saying, Ben, you're sick, but if you do what I tell you to do, you'll get better. And the way we do that is under the rules because we want to align with payment codes because, again, physicians have to run a business and they need to get compensated for their time and effort they put into it. Our patients, through technology, receive 3 clinical questions every day from the physician. The patients take about 20 seconds to answer those questions, and there's other opportunities involved in there. Now, 3 questions doesn't sound like much, but at the end of a 30-day cycle, you've got 90 questions asked. Most of the questions have some frequency. Our questions change every day, but think of something like our friend the pain scale, the 0 to 10 pain scale. That might be asked 3 or 4 times within 30-day period,
Right.
enough to make it relevant, but not to make it redundant. And you can get a pretty deep picture of what's happening with the patient over a 30-day period. So even though you're in the ER, I'm sure you've seen patients in E&M visits.
Yeah.
First thing you do in an E&M visit, Dan, how you've been doing the last 30 days, some variation of that. Patients tell you one of two things. They tell you about the last 48 hours or the acute event that brought them in, but they have no way of providing you with details of what's happened over the last 30 days. With a quick glance at the data that our patients develop, a physician going into an E&M visit can take a look at the summary page of the 30-day data and
Hmm.
quickly see, yeah, Ben, I'm very happy with your pain management. It seems to be going well. You're able to function the way you wish. You're attending work. You're playing with your grandchildren. All of that's great. But I've noticed here that you say you're taking substances to help you sleep at night. The pain's bothering you at the end of the day. So first, let's talk. Is it Chardonnay or is it Ambien? And what are some of the reasons? Well, now you've got a time management tool because physicians get 10 minutes for an A&M visit. That's the dirty little secret of medicine. Yeah.
Yeah.
You may
Don't tell too many
spend,
people.
yeah. You may be the patient that ends up spending 90 minutes going into the doctor's office and coming out, but 10 of those minutes are spent with the doctor. If you spend 2 of those minutes explaining why you're there, that's 20% of your time when the physician already knows. And we start talking about your issues. It's time management for the physician, and it also creates stickiness because the patient now knows that you know what's wrong with them. And we can add standardized assessment tools, PHQ-9s, GAD-7s, that type of thing to replace questions on days. We track and trend all of the data that patients get. We keep track of the time for them. One of the keys in the CARES Act, again, as a drafter, I know what the back doors are, is physicians need to provide documentation to make sure, excuse me, that they're operating within the standard of care for
Yeah.
medicine.
Yeah.
Now, what's the hardest thing to do after treating a patient? Finding time to document everything that you did. Why? Because there's another patient that's standing there and is far more interested in your time than you sitting down and documenting. So we provide automatic documentation that goes to the second for every member of the office, what they did in the care and treatment of the patient.
How do you do that?
We do that through automation.
Okay. Is that like AI stuff? Is that like a
It's
listening, ambient listening or something?
It's a combination of machine learning, and we're just starting our AI programs. I mean, for example, we will shortly have avatars for
Wow.
physicians,
Cool.
where we have a program where you have a hard time telling that it's not your physician talking to you.
Yeah.
But instead of manually enrolling patients, for example, the physician will be, Ben, before you come in tomorrow, I want you to know that I'm going to prescribe as part of your treatment our practice app. So I'll be able to talk with you every day and find out what's happening during your course of care. Please fill out this application as best you can so that we can get you going right away.
Hmm.
Now, that's what we do now in machine learning, where we transfer the data from the patient's electronic health record. Some of the data that we need isn't available there. Do you have a iPhone or an Android? What's your cell phone number? Even your email address. But a lot of the information we can transfer. Now we're just asking the patient to put that information in. We come into the office and we push a button, locked into the
Right.
system.
Right. Right.
You'll get another message from me the day after our appointment. Good morning, Ben. Today's the first day you'll be getting questions. As we talked at our appointment, this is very important to your care. I want you to do this. The avatar has no lag in their conversation.
Wow.
For the physician, it takes a photograph and a 2-minute series of words that they say, a speech, and the AI grabs each word and can create not only full sentences out of it. It can do it in 140 languages.
Wow.
We have one physician who uses the avatar whose physicians come in and speak Spanish to him, because his avatar spoke to him in Spanish. Of course, he speaks no Spanish at all, but that's a good problem. So we are going into the AI transition. Our questions, we enlisted some of the top physicians in pain management as an
Yeah.
example, or pain vertical, to create our initial clinical questions. All of the questions are designed around how you talk with a patient in a visit. So let's talk about that. The polite term is patients can be inaccurate in describing their signs, symptoms. The more accurate terms is patients lie, but they lie as a golfer may lie about their handicap. It's one of two directions. They either want you to think that they're better than they are, or they want you to think that they're worse than they are. And they don't even do it consciously. And you're trained in PA school, in medical school, by asking a series of questions is how to get the answer. It is one of the most difficult fields because we don't know what it means for someone to hurt, someone
Mm.
else to hurt. We know what it means for us to hurt because we've all experienced pain in our life. That 0 to 10 pain scale, you and I may have the exact same amount of pain, and I may call it a 4 and you might call it an 8
Yeah.
for a variety of reasons. And the answer needs to be, you need to find out what type of pain Dan's in, what type of pain Ben's in, and what's the appropriate treatment for that pain.
Yeah. Yeah.
The appropriate treatment may be none at all, by the way.
Right.
And so if patients are on scheduled substances, for example, and they're convinced that that is the most appropriate for their treatment, they may suggest that their pain, if they have a choice between saying it's a little greater or a little lower, may say it's a little greater just to ensure that they're going to continue to get the treatment. Well, you already know that. So what you're asking are other related questions about work attendance, about sleep patterns, about able to function with the level of pain you have. Because when you talk to a pain patient, we're telling them, we're not going to get you out of pain. That's not what pain management is. What we want to do is get your pain level down to a manageable level so you can live your highest quality of life possible. And when you have that, you try and get those questions out of the patient. Well, our clinical questions do the same thing. They have the
Mm.
direct inquiries that patients ask. We have follow-up questions. One of the challenges with AI in healthcare is AI is designed to be subservient right now. And so it's not good for predictive care and it's not good for recommendations. Or we like to say, Dr. Google really doesn't know. And the reason is they don't ask the follow-up questions that you would ask. And when patients Google something, they don't know how to ask the question of AI. So if we have a question, for example, one of our questions is, did you take any non-prescription medications over the counter? It's a yes
Mhm.
or no. Now, every question has a normative range in the background, and you may have said, I don't want you taking anything without telling me, so you want the answer to be no. If the patient asks no, they go on immediately to the next question. But if they answer yes, immediate follow-up comes up, and
Mhm.
it's, what medications are you taking? And then has the 5 most common classes of
Right.
medication in simple terms that a patient would understand. And when the patient's response comes back on a daily basis, there's a quarterback in the office, typically an MA, that reviews all the responses.
Wow.
And by the way, this is no different than an MA taking a phone call from a patient calling in. You look at the answer or you hear the question, and then you make a judgment as to whether or not I can handle it or I need to
Mhm. Mhm.
extend it to someone else on staff with more training.
Right.
And we capture all of that. Every time the patient's record is open, a clock runs and it captures the time. When the practice does something in the platform, all of that is captured.
Mm.
Even telephone calls. Patients on our platform, practices anecdotally report that the telephone call volume drops between 30 and 40%.
Mm.
Why? Because the patients are, I'll say, but it's in a secure environment, so text doesn't
Right.
quite capture it, but a secure text, if you will. Patient texts. Now, when a patient calls into the office, I want to speak to Dr. Ben. I've got a problem. Dr. Ben would love to speak to you, but he's in with the patient at the moment. Let me know what's going on so I can, I'll get you to someone else on the office. Patients don't like it. Dr. Ben's always in with patients, whether it's true or not. He's always in with the patient on a phone call, and it goes to a nurse. So let's just Pretend for a moment that the nurse is available to take the call, not that it goes to voicemail. You're in a customer service industry. So you have to let the patient explain what's going on. So a quick phone call is 5 minutes. You get dozens of phone calls a day. So let's say we reduce the call volume by 40 phone calls.
That's a significant portion.
That's the 200 minutes of somebody's time to deal with those 40 phone calls. And by the way, those phone calls are a billing opportunity that you can't bill for. There's no way to capture that time. But if you go through our platform and the nurse or whoever the query has been escalated to, when they have their break, they look in and they can answer 5 or 6 queries in 30 seconds to a minute each just by typing out a response. Most of the time, it's a prescription refill or I have an ache here. Well, let's bring you in, that type of thing.
Yeah.
That time is captured in the platform and is eligible for a billing decision. It's not a big deal, but it's a little bit of accretive revenue.
Yeah. I was going to say that still moves the needle some.
And the thing that really moves the needle for most practices, the most logical person that switches from phone call to texting is the frequent flyer in the office. For some reason, they just, they want that personal relationship, and now they're texting with the doctor, even if it's a nurse or an MA or
Yeah.
someone else.
Yeah. Yeah. And so, from my understanding, from what you've described so far, and for our listeners' sake, you have your own panel of physicians. But then, are you
That was the starting point.
starting point? Okay, because now we're transitioning to more of a software as a service kind of model, correct?
This is a SaaS model. And what happens with those? We came to market with 75 clinical questions in the pain library. There are now over 450. Why? Because physicians say, great question, but I ask it this way, not that way. Or you're missing something that I find important. What we do is we created default protocols, and the initial were basically two, medically managed pain and interventionally managed pain. Now we have some 22 different default protocols in pain. We've added fibromyalgia and rheumatoid arthritis and other related issues from our physicians. We want them to create their own protocols, and we in turn put the protocols up for any practice to use. To change a question is simply 2 clicks, one to X out the old question and one to drop in the new question. You can do that at any point in time. If you create your own protocols, you're getting the information that you need to treat the patient based on your experience, your skill set, your patient population. And that's what we want to be. And we capture all of that data. For us, we're ultimately a data analytics company. We have nearly 1 million patient daily records. We have nearly 4 million, and both those numbers will be surpassed by the end of this month, ePROs, electronic patient reported outcome data points in our system. And that's been providing us with good data for publishing papers and abstracts.
Right.
But down the road, that data will be useful to payers, will be useful to physicians, useful to clinical trials, where you can actually come to me and say, Dan, tell me about 50 to 60-year-old males with a primary diagnosis of pain secondary to A1C. What's their outcomes in that age group in New England compared to Southern California? And you start to get to best practices because we everything about the patient except their name.
Right.
All of their demographics, their ICD-10 diagnostic codes, and their treatment patterns. So we can see when patients are getting better, we can see when patients are decompensating, and we can provide that information ultimately.
And that's incredible. I mean, that's the dream of where to get it to. Where are you selling this product more to like private offices at this point and physicians that are privately owned, and we're hoping to transition more to like larger health organizations?
Yeah, right now we're with larger physician practice groups.
Okay. Yeah.
We've made the transition from the individual office to the practice groups. Hospital systems and other systems are still a bit in the future because they require more data. They also think that they can do it themselves. And then once they fail, that's when they go out to companies, have some expertise in the area. And it all tends to work fairly well together. And for us, our focus has been chronic care management, and we have pain as a vertical. It's not a pain platform. So our approach works for bariatrics, both surgical and clinical, particularly with the challenge of GLP-1s.
Yeah.
It works for behavioral health. It works for substance use disorders because every one of them has a different issue. I'll pick two related: pain and substance use disorder. What our platform provides ultimately is care plan adherence and medication management. Well, if you're a pain patient, we don't have a medication management issue by and large. Pain patients take their medication. Now, we may be concerned that they're taking too much for certain patients, but if you get a script, they're going to take their drugs. So it's more care plan adherence and what are they doing to improve their situation. Substance use disorders, the opposite. We have an 83% failure rate, a 17% success rate nationally with substance use disorder.
Wow.
And the primary driver of that is medically managed substance use disorders with buprenorphine or some of the related drugs. Med management is in the toilet.
Yep.
If we could get patients to take their medication, we would see some improvement. I'm not talking going 17 to 80%, but going 17 to 19, 20, 21%
Yep.
have huge impact on the issue. And so
Yeah.
that's where we can have some impact with patient populations that aren't used to complying with their medication.
Hmm.
And what happens, you know, we don't need to ask the patient, are you taking your drugs every day? Because again, go back to my postulation earlier. Patients tend to lie and they tend to tell physicians what they think they want the physician to hear, or at least what they want the physician to believe about them.
Right.
Substance use disorder is saying, yeah, I keep taking it, but I still have cravings. Well, when you ask all the other questions around what they're doing, you can get a pretty quick picture. Dan probably isn't taking his medications or he's not taking them as regularly as he should. And so instead of waiting for your next appointment, which could be 60 days in the future,
Right.
I'm
Right.
going to bring you in now and we're going to have a session. We've had, anecdotally from offices, all sorts of saves of early warning. The most recent one was our fibromyalgia and
Mm.
rheumatoid arthritis practice in California. And this is the physician there is a power user. He loves data. He's,
Mm.
as an MA managing it, he's going in and checking patient records all the time. And anytime the patient writes in, he wants to see it. Well, one of the patients wrote in and said, I'm having some issues today. I can't quite close my mouth. The left side of my lip seems to be drooping. If something doesn't get better in the next 2 or 3 days, I probably want to come in to see you. And he picked up the phone and said, you're having a stroke. Let's go to the hospital right now. And of course, he was correct and got the patient to the hospital. But for the platform, the patient would have waited 2 or 3 days with a different uncertainty of outcome. And I can tell you other stories about medication mix, about behavioral health patients that have gone off their meds
Right.
and had a crisis. And in all of those cases, the physician wasn't scheduled to see the patient from anywhere from 2 to 16 weeks in the future.
Hmm.
And having that touch point change patients' lives for the better, which is the feel good story. But if you're looking at healthcare as a business, you're also saving enormous amount
So much.
revenue for the system. You work in an emergency room. For 16 years, I was on the MedStar Health Board. MedStar is the largest mid-Atlantic hospital system, where I was board chair for the National Rehab Hospital.
Hmm.
Across the street from us and connected is the Washington Hospital Center, which is our level 1 trauma facility. And now, 3 years ago, when I was still there, I know what the cost is of our level 1 trauma facility. $17,200 every 24 hours in our ER. If you can prevent a patient from going to the ER by appropriate treatment, you save an enormous amount for the system.
Yeah.
And that's one of the things that we will be trying to look at as we look at outcomes data.
It'll be really cool to see. I'm excited to see that.
Yeah, yeah. And, kind of a last thought, because you started on AI and machine learning. One of the benefits of AI is every bit of information that's ever existed has been scraped and is not available. So the future markets are for new information. And we're developing new information every day from every one of our patients who are providing information to their physicians about what's happening with their treatment at their stage of life, at their age, at their weight, at their ICD-10 diagnostic code. We learn an enormous amount. And that's where the real value is, because eventually we'll get into predictive analytics. And I say eventually, I know a lot of people say we're already there. I don't think we're there with AI yet.
Yeah.
In healthcare, AI doesn't ask the right questions yet. Its prediction is great for the 80%. But, I'm not a physician, but I could treat the 80% because there are certain rules for the 80%. It's your skill set, your colleague's skill set is not for the 80%, it's for the 20%. When it's just a curveball, AI no more than I'm not even a pseudo physician. I just play one on TV. We don't have the skill set for the 20%.
Right. Right.
We'll never get it. AI eventually will, but I'm not ready to have a patient be treated because AI said that this was the right thing to do.
Yeah, you just need more time. I think from that perspective, I mean, my outlook on that and kind of what I've heard across the board is that it just needs a little bit more time to train. It needs more patient encounters. It needs more data, basically, to be able to build predictive models.
Well, and interesting, there was an article on the Washington Post this weekend where they looked at 12 different scenarios of patients asking AI questions, if you will, and a physician graded the AI response. And in essence, 4 of the responses the physician felt were perfect. The advice given to the patient was spot on. 4 were so that while they missed something, they weren't endangering the patient per se, because there was always, you should go to your doctor at the end of it. And 4 would have caused adverse health outcomes. All of it was based in, they didn't make this in the article, but I read the questions, I read the answers. There seemed to be a clear line that it's the way the patient asked the question. And if you have, for example, a suicide ideation in the question, depending on how you ask it, AI was either giving the perfect response, you need to go see somebody, or it tried to explain why suicide may not be the best issue for you, which you can see people running around with their hair on fire, and you can't have
Yeah.
this answer.
Yeah. Yeah.
And
Cut that out.
we're in that state with AI right now. AI is
Right.
amazing, and I think is the future for healthcare, but it's the future that's in the future. It's not here yet.
Point. Speaking of future things, as we kind of compile our thoughts together, where do you see kind of Adhere Plus going? And obviously, you've talked about the different medical advances and the different clinical advances that are going to come that you're developing and just waiting for the data to continue to return. Where do you guys see yourself? I mean, kind of in a growth standpoint, come, let's say, this time next year?
Well, great way to ask the question. And there's some parallels that I look at. 20 years ago, electronic health records first came on the market. In 2005, 2006, it was early adopters who saw the potential that would do this. And then most of the physicians whose hair color is closer to mine than yours, who owned the practices, said, we're not doing this. We like our record system the way it is. That went through a process of early adopters to reasonable records to a real process to market capitulation. And that happened between 2005 and 2009, 2010. We're in the same cycle, if you will, for telehealth and telemedicine. Are seeing initially when we went to market after beta commercialization a little over a year and a quarter ago. And we had gotten past the early adopter phase. And that's important because in the early adopter phase in our industry, a lot of fly by night service providers and maybe some sketchy physician practices that,
Right.
where everything was buy our service in February and buy your own private island in June, where it was money and it wasn't about data. And it was about practices that like to walk up and over and on top of the line as opposed to providing care. Now
Hmm.
we've gone past that stage. Physicians know about telehealth and telemedicine much more than they did a year ago. And we don't have to explain as much what we're doing as much as we're explaining how we do it and how it integrates into the practice and how it works for the physician. A year from now, the occasional incoming call that we're going to get, I suspect, will be markedly different, where practices are going to realize that this is coming, this is going to be a part of their practice, and they want to talk to different providers. By the end of the decade, by 28, 29, every practice will have some form of telehealth. And the reason is it's a force extender. So let's go back to where we started chatting about rural health and why telemedicine came about is because of the lack of the healthcare providers in rural areas. And
Hmm.
even in suburban areas, there's a shortage. That shortage hasn't improved. It's been exacerbated. So physicians can manage more patients with our platform, manage them more effectively. And whether it's ours or some of our competitors who also do a very good job, by and large, the industry has eliminated the fly by night folks because their
Right.
business model wasn't going to last. It allows practices to effectively treat more patients. I'll give you an example as we launch our bariatric surgical practice.
Hmm.
A bariatric surgeon typically can manage 325 patients at one time, plus or minus 25 patients. That's the bandwidth they have. And if you're going to have bariatric surgery, most payers still require a burn-in period that is designed to last about 6 months of psychosocial evaluations, ability to lose some weight and maintain that weight loss, and other issues before they'll approve a surgical procedure. Again, that process is designed typically to last about 6 months. It realistically lasts between 11 and 14 months. Now, using our platform, we can manage those daily interactions with the patients, make sure they have going to their appointments, get questions answered, help them with their weight loss journey and the like. Our data suggests that we'll be able to reduce that 11 to 14-month period to 8 or 9 months. Now, nothing's changed for the surgeon's practice, except he now has a 30% greater throughput of patients. So that helps his business. Providing the same amount of care, we're providing an efficiency that he or she doesn't have in their practice.
Hmm.
We're going to be able to develop data around GLP-1s. GLP-1s have the same liability that other weight loss drugs have had over the last 30 years. And that liability is patients tend to discontinue use after 6 months.
Hmm.
Once you discontinue use, patients rapidly regain the weight that they
Right.
lost. So it becomes a very expensive proposition. But in surgical practices, patients need to lose 3 to 5% of their excess body weight and maintain that weight loss as a marker to show that they will be capable of managing their new self after a sleeve gastrectomy or a biliopancreatic diversion with a duodenal switch or whatever
Yeah. Yeah. Yeah.
procedure the physician uses. Well, if the patient uses a GLP-1, have they achieved that marker?
Right.
Probably not, because
Right.
that didn't deal with the patient's capacity. And obviously, one of our concerns about those patients is some patients don't want to lose the weight. The weight is
Yep.
protective. And that's why you need a good psychological evaluation. Is the patient able and ready psychologically to lose the weight, much less physically, as an example? And of course, lastly, bariatrics is a chronic condition that we treat as an acute disease, but that's another subject entirely. And
Yeah.
we'll do another show on that.
Yeah, exactly. No, very cool. Very cool to see kind of the growth and also, the direction that we're heading. I'm really intrigued to see. I mean, it sounds like this product, honestly, I call it a product because it's kind of a platform product at this point, but the benefits for the individual are why we're doing this and why you're approaching it this way. Obviously, you save a ton of healthcare costs in the background, but I just hope the listeners can hear that this is a thing that can work. It can help support a patient to actually make them feel heard and listened to so that they're not approaching Google for their answers.
Well, and they still will, so you have to manage that. But what you are doing is providing what most patients believe they want and they should want, which is proactive care. But the only way to have proactive care is to pay for it. So if you pay for it at the front end, you should have a healthier patient downstream, which saves everybody money. And for the patient, it changes their life. That's really where we are. So everything you said is true, but we're also support the business proposition of the physician's practice. There is accretive revenue that goes to the patient, to the practice from the patient, and that adds into the entire service module of the practice. Patient acquisition is a concept that most physicians don't think about, but
Nope.
there is a cost to acquiring a patient, advertising, talking to colleagues, and the like. And the longer a chronic patient, which by definition is someone that's not going to get better, they're going to be managed, and they're going to be managed by someone. So if the patient is unhappy with the service that Dr. Ben is providing, the patient's then going to go to Dr. Dan because someone has to treat them. But if Dr. Ben can keep the patient longer, that benefits his practice and his business model. And
Hmm.
if he's keeping him longer, that means the patient is happier, which means that they're getting the type of treatment they're looking for.
Yep. Easier to keep a patient as well rather than going to prospect for one
Absolutely. And that
anytime
anytime. And that's really where we see a major benefit of our platform.
is retention.
It creates a stickiness between the practice. Why? Because if you use our platform as designed, you'll be able to tell the patient what's happening in their life because the patient already told you over the last 30 days what's happening in their life. So you know what needs discussion and treatment and what you don't have to waste time on. Time management tool, but also patient satisfaction tool. Dr. Ben knows what's bothering me, and we're dealing with that right away. We're not dealing with all the extraneous issues. I am a person and not a
Yeah.
cog in the system.
Yep. Yeah, very cool. I hope that it continues to grow. I mean, as we kind of tie things off, I'm really grateful that you guys, I mean, you unretired to be able to develop this platform.
Well, I'll stick around for a while. I love the benefit that we're creating.
Yes, yes. I do too. I mean, this is something that the reason we have guests on the show is to be able to highlight people like you who are creating products to help people, not just to, like you said, to buy an island. It's not about that. It's about the downstream effects of helping more people and making sure that they're taken care of.
And for the first time in my healthcare career, I've got something where physicians from the jump can get compensated for their service,
Which is massive
which
because
is,
all that we've seen in healthcare is everything's declining.
well,
Reimbursements, I think.
as we get to the end, let's go back to where we began. I talk about bringing Apodaz to the market. There are 80 million scripts monthly for Vicodin now.
Mm,
That's the most prescribed opiate in the country. So when you have something that has the exact same clinical effect, Apodaz does, as Vicodin, you would think that would be beneficial to society because you would reduce particularly intranasal forms of abuse. So that's good for the patients who need the opiate for their acute pain. And it's good for society for people that are misusing it. They don't get the benefit from it, and so then they wouldn't use it. But there's a problem. Apodaz is a brand new product. So it costs on average about 9-10 cents a tab. The lowest end you can make it because it's new. Vicodin costs about 1.5 cents a tab.
that's
So
a big difference.
payers, they're not particularly concerned about the opiate abuse problem. They're more concerned about profit lines. So generic Vicodin is preferenced over name brand Apodaz. You're in an ER which uses opiates to treat pain, particularly acute pain, on a regular basis. I would be surprised if you told me that you had Apodaz in your inventory, but you have Vicodin.
Yeah.
So, and that's part of the healthcare conundrum of the system is we want new innovation. We want new products. We want new medical devices. We want new drugs, but we don't want to pay for it.
Right. Right.
Uh, and so that was my first 20 years in healthcare was creating new and better mousetraps, or at least I like to believe they were new and better mousetraps, but couldn't get paid for them or had to go through a process of 2 to 4 years, which is why big pharma and Medtronics and the big device companies have an advantage over all the innovators
Right.
because they have the resources to get a product from today's approval to the future's reimbursement.
Right.
In here, we're clearly an innovative company. We're in a market full of good, innovative companies. And by the way, competition is great. I think it's a wonderful thing. We don't have a McDonald's, Burger King, Wendy's all on the same street corner yet, because there's far more business than there are quality companies providing the service.
Totally.
But we're all of us are able to go in and provide a product that provides benefits to the patient, benefits to the practice, and the practice can get compensated for it. So they're interested in adopting. That's why I put it in the EHR realm, where over a 4 to 5 year period, if not quicker, this is going to go from unique to ubiquitous.
Yep. I mean, it's just very exciting. I hope that this continues to grow as we
So
kind
do
of,
I.
obviously that's why you're here. That's
That's
why
why
you're
I'm
doing
here.
it. Yeah. But yeah, I would say, to all the listeners, just watch this space. Dan, it'd be pretty fun to kind of maybe reconnect next year and just see how things are kind of continuing to progress and how much more uh, kind of like the machine learning is progressing, but also, just the business overall, maybe even doing a reconnect.
Well, but I guess I didn't answer that question directly. Next year, we will clearly have AI components. Not only will we have the avatar physician, the questions you get today will help determine the questions you get tomorrow.
Yep. Yep.
And we think we'll be able to bring that out before the end of next year as well as we develop those aspects. So it's
Really
exciting.
cool. It is very exciting. It's very exciting to see, and even just progressing into these different chronic care kind of developments, bariatric surgery and whatnot, and behavioral health, and continuing to progress, getting your fingers in more practices to be able to affect and help more patients. So,
Well, and that's the benefit of an MSK diagnosis. Musculoskeletal conditions
mhm,
are very broad. These are anytime codes because the benefit exceeds the cost for virtually any disease state that's chronic.
totally. Well, Dan, I think that's about all the time we got for today. Thanks for your time and just honestly sharing so much, and just continue to hope for great things to come.
I appreciate it, Ben. I've really enjoyed our conversation. I look forward to the next one.
Yeah, sounds good, Dan. Thanks a lot.
Bye bye.